All right, all, we're going to get going. Welcome back to Grand Rounds after a summer break. This is our third Grand Round, so we appreciate everybody being here in person and a good turnout today. A reminder, your CME MOC can be obtained here with the new state regulation going in 2027. This is important to have 20 CME points every 2 years once you go and get your state license renewed. So please take advantage of the CME MOC credits that you get there. I'm pleased to introduce Dr. Ben Glick. Ben is an assistant professor in the Division of Gastroenterology here in the Department of Medicine. He did his undergrad in Virginia at the University of Virginia, and he went on to UPMC for his internal medicine training. He went on to GI and hepatology fellowship at UPMC from 2015 to 2018, and at that time, he was a chief fellow and was also a T32 scholar. He also received his master's in clinical research at that time from UPMC. He then went to Cleveland Clinic for 4 years, where he was a staff gastroenterologist, and then we were fortunate enough to recruit him here to the University of Colorado in 2002 as an assistant professor. His research interests are primarily focused on risk prediction and optimal management strategies for postoperative Crohn's disease, and this includes the collection and organization and utilization of large-scale observational data for natural history studies. He's also found out today associate editor and social media editor for Crohn's and Colitis in 360. I just sent him a friend request on Twitter. He served on multiple investigations and clinical trials in relation to IBD. He's a national and international speaker on the topic of IBD, and since fellowship has published over 60 papers. So please welcome Dr. Glick for Grand Rounds today.
All right, well, thank you for the very kind introduction. And as social media editor, I guess I have to correct you that it's X, not Twitter now. I still have like the version of Twitter from 6 years ago, so forgive me. Well, I'm really honored to be speaking today. I'm Ben Glick. I'm an assistant professor in the Division of GI and Hepatology. Really honored to be speaking about a topic that's near and dear to my heart, as you recently heard, that's postoperative Crohn's disease. And what I hope to do over the next 45 minutes or so is really highlight some key dilemmas in this high-risk patient population and some efforts and some strides that we've made over the last few years to help manage these patients. These are my financial disclosures. Let's start with a case presentation. We're going to be talking about a 32-year-old female with ileal Crohn's disease that was diagnosed 2 years prior. She had an initial therapy of mesalamine combined with a budesonide taper and is now presenting with increasing abdominal pain, nausea, vomiting over the last 6 months. She was actually started on adalimumab, an anti-TNF monoclonal antibody, about 4 months ago, and really notes that she hasn't experienced much clinical improvement since that time. Her last colonoscopy was performed at the time of diagnosis 2 years ago, which reportedly demonstrated moderate inflammation in the terminal ileum, and she's an active smoker of 3 to 5 cigarettes per day. She undergoes a colonoscopy to reassess her disease burden at this point in time, and I recognize that much of the audience doesn't spend their day looking at the insides of the gastrointestinal tract, but just to highlight that this is the terminal ileum. You can hopefully imagine that there's not much room to push forward here. And what we're really seeing is that the terminal ileum is narrowed down, it's severely inflamed, and right in the middle of that picture there with kind of the whitish base is a big, deep ulcer. So this is concerning for a stricture in the setting of Crohn's disease. We actually could not pass the colonoscope through this segment here. And this was confirmed radiographically when she obtained a CT enterography, which showed on the left there an area of narrowing in the terminal ileum, and on the right you can see wall thickening and mural hyperemia consistent with active inflammation in this segment. More proximally, there's small bowel dilation, suggesting that this is a stricture with pressure gradient, and the pressure in the small bowel is building upstream from this, and this is likely responsible for her clinical symptoms. So she undergoes an ileal resection with anastomosis, or reconnecting the small bowel and the colon. The surgical pathology demonstrates markedly active chronic ileitis with ulceration, non-caseating epithelioid granulomas, focal areas of myenteric plexitis, including the proximal margin, which we'll talk about shortly, and confirming the diagnosis of stenosis. Fortunately, she has a normal postoperative recovery. She's discharged a few days postoperatively, and she comes back to your clinic 2 weeks later, along with an appointment with the surgeon, and ask the question, what's the plan? Where do we go from here? So like every good medicine talk, let's start with some epidemiology. In Crohn's disease, unfortunately, surgery is historically very common. So it's estimated that within 10 years of diagnosis, approximately 50% of individuals with Crohn's disease will require some sort of surgical intervention to help manage their disease. The good news is that over the last 20 years, with the advent of new mechanisms of treatment, our biologics, our small molecules, as well as changes in paradigms of management of Crohn's disease, we've seen a relative reduction in the lifetime surgical risk, but it's still pretty predominant at 26%. The most common indications for surgery in Crohn's disease include disease-related complications, as in this case with a stricture, what we call penetrating complications, which are intra-abdominal abscesses or intra-abdominal fistulas, medically refractory inflammation, or the development of neoplasia or dysplasia in the setting of Crohn's disease. Due to the anatomic predilection of Crohn's disease for the terminal ileum, the most common area that's affected, the most common surgery, therefore, is resection of the terminal ileum, which is performed with an ileocecal, or what's also called an ileocolonic resection. And this involves removing the disease segment of the terminal ileum, along with the cecum and the appendix, and then anastomosing or reconnecting the proximal colon to the distal small bowel. And for a point in time, these individuals generally are macroscopically and microscopically free of Crohn's disease, so a state of surgically induced remission. The unfortunate reality in Crohn's disease is that surgery is not curative. We know from natural history studies that have been performed over the last 40 years that have helped really delineate this, that Crohn's disease tends to recur in the majority of people who undergo surgery for management thereof. And let's just walk through some of the natural history and this disease progression that we can experience and witness when we perform surgery for Crohn's disease. So if an individual undergoes surgery, it's been shown that within 1 week, if they take biopsies of the small bowel just proximal, just upstream from the reconnection site, they can actually see histologic activity of Crohn's disease. So very fast microscopic recurrence. If we perform colonoscopies on these individuals within 1 year of surgery, in up to 90% of individuals, they will have some degree of small bowel inflammation as evidenced on colonoscopy imaging. This goes along with other measures of disease activity, radiography, biochemical measures of inflammation, and those tend to happen synchronously. What's really interesting with postoperative Crohn's disease is that we see a relatively low rate of what we call clinical recurrence. This means the return of signs or symptoms that are consistent with Crohn's disease, like abdominal pain, change in bowel habits, weight loss. And you can see that only 30% of people within 3 years and 60% at 5 years experience clinical recurrence, so much less than the objective disease activity as witnessed on the previous assays and tests. Unfortunately, if left to its own devices, up to 50% of individuals who get surgery to manage their Crohn's disease will require a second surgery to help manage that Crohn's disease. So it's a highly morbid natural history for these patients. What this also tells us is that this progresses along a continuum of microscopic to macroscopic. And it's really one of the few opportunities, at least in the diseases that I routinely deal with, of being able to watch a disease establish and evolve in front of our eyes. Oftentimes we make the diagnosis of a disease when it's already existing and we implement treatments to help manage it. But this is one of the true interventions in disease states where we have an opportunity to alter this natural history. What these parameters also tell us is that, unfortunately, the recurrence of disease activity is often clinically silent. If we sit and wait for these symptoms to develop, we're catching it too late. This disease has been in place for many months, if not years, preceding the development of symptoms, and we may have missed our window of opportunity. And that's an important point when it comes to how we monitor and manage these patients. So I want to go through some key dilemmas that we're facing in researching and managing postoperative Crohn's disease in particular. So if we know that the majority of people will experience some degree of disease recurrence, objective disease recurrence, that is there a way that we can accurately identify individuals who are at highest risk of this? Who comes back the earliest? Who comes back in the most aggressive form? And who's really that 50% that if left to its own devices would need surgery in 50%? So there's an element of needing to be able to predict this patient population. Furthermore, if we know that the majority of people will have some degree of disease recurrence, is there an opportunity to actually intervene and prevent the establishment and the development of this disease process, especially when it comes to medical therapies? And so we'll be talking about that as our second dilemma in postoperative Crohn's disease. Third, if clinical recurrence is late and in the minority of people, how do we optimally monitor for disease activity and disease recurrence following surgery? Is it endoscopic? Is it radiographic, biochemical, some combination? How often? When do we start? And these are some of the key lessons that we need to learn in this high-risk patient population. So let's walk through those one by one. So dilemma number one, can we predict who's at higher risk for postoperative recurrence? This is not a new dilemma. This dilemma has been around since we established this natural history of Crohn's disease after surgery. And I'm not asking you to read this table. This table is just meant to show that a lot of studies have looked at this, a variety of different clinical risk factors, disease-related factors, genetics, serology, microbiome, details about the surgery and histology, as well as other omics, have really sought to define who's at high risk. And what I want to point out is that there's a lot of discordance between studies related to these variety of different risk factors and whether or not they're associated. But there's a couple that continually stand out on study after study. And this relates to active smoking. So people who actively smoke at the time of surgery or after surgery are at much higher risk of having Crohn's come back. Similarly, with Crohn's disease, history tends to repeat itself. So if a person requires surgery for Crohn's disease, they're at a much higher likelihood of, again, if left to its own devices, requiring additional surgical resection. And then there are some key risks related to disease behavior. So what we call internal penetrating disease, which is this Crohn's phenotype where people can develop fistulas and abscesses within their intra-abdominal cavity, or actually perianal Crohn's disease. So perianal fistula, perianal abscesses, regardless of what's happening within the lumen of the GI tract, seems to be an independent risk factor for Crohn's disease coming back after surgery. So taking all these variety of different risk factors and their relative associations, the American Gastroenterological Association put together a very nice technical review in 2017 and a clinical practice guideline, and they helped us establish risk strata for predicting who is at highest risk for recurrence of Crohn's disease following surgery. And what they laid out is that the lower risk population are likely patients who are older when they're diagnosed with Crohn's disease, who are non-smokers, who this is their first surgery for Crohn's disease, especially if that Crohn's disease has been in place for many years, has been very slow to progress and evolve towards needing or requiring surgery, and especially if it's a relatively short segment of small bowel involved. And it's estimated, putting all these natural history studies together, that in this patient population, the risk of clinical and endoscopic recurrence is between 20 and 30% respectively. Comparatively, the higher risk patients are those who are diagnosed really early in life, less than 30 years old, who are active smokers, either at the time of surgery or in the postoperative course. And like I mentioned before, who've had multiple prior resections for Crohn's disease with or without perianal involvement. Again, it seems to be an independent risk factor for recurrence of Crohn's disease. These people are the highest risk. So 50% clinical recurrence likelihood and 80% hypothetical endoscopic recurrence within a year and a half of surgery. So that's kind of where we stood for a few years. And as you can look at the clinical characteristics that are included here, this is all clinical. We don't see any mention of histology, microbiome, anything that we read journals nowadays and read about being explored in research. So I want to spend a little bit of time really going over some of the more recent advances as it relates to risk factors and prediction of postoperative Crohn's disease. I think I would be very remiss if I was a gastroenterologist and didn't present at least one slide about microbiome. It's the hot, sexy topic, right, in GI and the association with various disease outcomes. There's a really nice group in Europe that has put together a prospective cohort of individuals with Crohn's disease undergoing ileocecal resection called the POP-REMIND cohort. And this data comes from that, where they've collected a variety of different tissue, stool, saliva samples from these patients over the years through their disease course. And what they have shown us is that there are certain microbiome signatures and profiles that are associated at the time of surgery with individuals who are at highest risk for developing subsequent disease recurrence. I'm not a microbiologist. I don't even think I can pronounce some of these phyla or organisms, but there's a relative increase in proteobacteria and a relative reduction in other organisms as well, and overall a decreased diversity seen in the microbiome when this was assayed. The group then went on to explore the role of a specific organism that they detected in the mucosal microbiome interface. So this is when we take biopsies on colonoscopy and look at the microbiome that is in close proximity to the mucosal lining. And this is in contrast to how we routinely measure fecal microbiome, where we collect a stool sample, do 16S shotgun sequencing, and kind of explore everything that's coming out of the GI tract. This is the really close proximity. This is where the true host microbiome interaction is occurring. And what they found is that a specific E. coli form, adherent invasive E. coli, is independently associated with risk of postoperative recurrence. So in 15% of individuals in that red bar there, this adherent invasive E. coli was found in the surgical specimen. So not everybody, 15%, but postoperatively that increased to up to 30% of individuals. And what they showed in a multivariable model looking at this is that the presence of adherent invasive E. coli at the time of surgery conveyed an over threefold increased risk of developing postoperative recurrence if that was present. So this actually led to the development of a selective antimicrobial compound that actually bound this adherent invasive E. coli, and it led to the excretion of this, and so it wouldn't be present in that mucosal microbiome interaction. Unfortunately, the phase 2 trial was stopped early due to low enrollment and likely some other issues, and so we don't yet know the fate or the possibility of this selective antimicrobial compound, but a very interesting phenomenon, association, and perhaps opportunity for intervention to consider. Shifting from microbiome to histology, what we've learned over the last decade or so is that there are certain histologic parameters that can be independently associated with this postoperative risk as well. So similar to oncology, if you look at the surgical margins and whether or not there's Crohn's disease activity right where the surgeons cut and reconnected the tissue, that perhaps not too surprisingly increases the likelihood that Crohn's disease is going to come back. If you're reconnecting diseased tissue, that increases the likelihood. But even if the margins are clear, there appear to be some independent parameters and characteristics that seem to convey risk. These include the presence of inflammation of the myenteric plexus as well as submucosal plexus. Those have both been shown to convey risk. And so there are some key surgical histologic findings that we can perhaps incorporate into our clinical decision-making as we think about risk stratification and prediction. We've talked about preoperative clinical factors. We've talked about some perioperative surgical histology, but what about the postoperative course, and how does that influence the risk that somebody goes on to develop disease recurrence? This is simultaneously published data from an Italian group as well as our group on the right there that looked at individuals who had a primary anastomosis, meaning they were reconnected during their initial surgery following resection, but unfortunately experienced an intra-abdominal complication. This is essentially a leak. When the surgeons reconnect the tissue, there's a little defect or a weakness, and the luminal contents extrude into the intra-abdominal cavity, causing an abscess, making people very sick. Fortunately, it doesn't happen very commonly, but if it does, it can be quite challenging and convey a high morbidity along with it. But these individuals who experience this risk appear to have experience this complication, appear to have an elevated risk of postoperative recurrence even much further downstream than the immediate management of that complication. We don't know why this is, but we've seen it now in several different patient cohorts. And so it appears to be a real phenomenon. The hypothesis we're teasing out currently is whether or not this localized infectious complication drives an immune activation in these already predisposed individuals with Crohn's disease, and that goes on to convey an elevated risk of recurrence in the long term. But of course, that's a hypothesis. We're trying to bear that out in data currently. So what I'm trying to suggest is that by incorporating some of these novel dimensions and modalities, we can perhaps improve our predictive ability. And this has been shown in several different studies. On the left is looking at combining clinical and histologic parameters, and on the right is combining clinical and microbiome parameters. And what we can see is that there's an improvement in our predictive ability with an area under the curve improvement by both of those models, albeit modestly. So it's not a clear game changer. It's not a home run that if we add these, we can 100 predict with certainty, but it's more evidence. It allows us to have a higher degree of certainty when we make these risk stratifications to help manage our patients. So if we're getting pretty good at identifying who's high risk for development of postoperative Crohn's disease, can we actually do something about it? Can we implement some sort of strategy or treatment to help prevent this natural history and this disease progression that we've witnessed in our natural history studies? The oldest data looking at this is the utilization of antibiotics in the immediate postoperative period. This was a randomized trial of ornitazole versus placebo. Ornitazole was dosed at 1 gram per day and started within 1 week of surgery, and patients took it every single day for a year following surgery. And what this randomized trial showed us is that there was a significant reduction in endoscopic recurrence of Crohn's disease within 1 year of surgery by taking ornitazole every single day. This has gone on to be shown can be achieved with metronidazole. The unfortunate problem with this approach, especially with this particular class of antibiotics, is tolerance. So a high rate of side effects, actually about 30% of people in the ornitazole group had to drop out due to side effects. And the benefit is very temporary. So as soon as the antibiotic is withdrawn, we see a rapid recurrence of that natural progression and natural history of Crohn's disease. So it's a very temporizing measure. So there's some implementation of this in clinical practice, but largely, I'd say more recently, and we'll review some data leading to this, this has fallen out of favor. We have a variety of different medicines that are approved now to treat Crohn's disease. If you watch any TV at all, there's probably 7 different commercials during any break for a new Crohn's disease or ulcerative colitis medication. And so these medications target a variety of different molecular mechanisms, and we have a handful of them now available to help treat Crohn's disease. But it really was a question of whether or not we could use these medications to try and actually prevent in a prophylactic manner this recurrence of Crohn's disease following surgery. So one of the pivotal studies in the postoperative world was this PREVENT placebo-controlled randomized trial, which randomized patients who were higher risk for developing recurrent Crohn's disease and underwent an ileocecal resection to either receive infliximab or placebo. And what we see is that there's a significant, nearly 50% reduction in endoscopic recurrence of Crohn's disease following surgery if they're treated immediately with infliximab. So clearly there's an opportunity and benefit to be gained with this anti-TNF modality. But it's not unique to infliximab. This is a table compiling various trials of infliximab in blue and adalimumab in yellow, a variety of different controls. Some were open label, some were randomized trials that were blinded. But the main point here is that across anti-TNFs, we see a significant risk reduction. So the rate of endoscopic recurrence across these trials is somewhere between 10 and 20% if they're treated with anti-TNFs, compared to approximately 50 to 80% if they're treated with another control or placebo agent. So a clear benefit signal that is across the mechanism of action. But of course, we have different mechanisms of action, not just anti-TNF in our armamentarium now. Hot off the press, or off the podium, I should say, this actually hasn't been published in full yet, is looking at another mechanism of action for this same purpose. This is vedolizumab. And vedolizumab, for those who aren't familiar with this mechanism, it's a selective alpha-4 beta-7 anti-integrin monoclonal antibody. What that means is activated lymphocytes use integrin signaling to hone into target tissue. And that's where they do their lymphocyte sticking, rolling, and migration into the target tissue. By blocking alpha-4 beta-7, which is only expressed on gastrointestinal tissue, we can invite a gut-specific reduction in lymphocyte trafficking into the gastrointestinal tissue. This means inflammation within the gastrointestinal tissue goes down as a result. So this study is called the Reprevio trial, is recently presented and will be published, I'm told, in the next few weeks. Essentially, it looked at vedolizumab compared to placebo in the postoperative setting to prevent endoscopic recurrence, very similar to the PREVENT trial, which I just showed you. And the takeaway is that this mechanism of action seems to work too. Significant reduction in endoscopic recurrence through using vedolizumab as compared to placebo. This probably conveys to other mechanisms of action too that we have. We just don't have this gold standard placebo-controlled trial for every single agent or every single mechanism that we have to treat Crohn's disease currently. But it's important that this benefit of prophylactic therapy may be time to initiation dependent. This is data from our group that looked at when a patient was actually started on therapy postoperatively and whether or not we could see the benefit extend beyond the immediate postoperative period or whether it was really time sensitive. And what we showed that it was really important, especially in the highest risk people, that you have to get them on the medication within 4 weeks to really see the clinical benefit, particularly with anti-TNFs. So there needs to be a plan clinically going into surgery for these patients of what you're going to do postoperatively and implement that strategy accordingly. So if we have interventions medically that can be used in a prophylactic manner to help prevent or at least delay the recurrence of Crohn's disease after surgery, the question then becomes, well, should everybody get medicine? These medicines aren't cheap, especially when you're talking about biologic medications, or should we do more of a risk stratification? And what the guidelines suggested is that we should use a risk stratified approach, where those individuals who are lower risk for Crohn's disease recurrence, again, about 30% endoscopic recurrence risk, we should likely be considering what we call endoscopically guided monitoring. Not necessarily start them on medical prophylaxis, but perform colonoscopy disease activity assessments. And if there is disease activity, then we can start therapy. And we'll go into a little bit of that data in the next coming slides. But individuals who are at the highest risk, 80% likelihood of endoscopic disease recurrence if we don't do something, these are the people who we should be utilizing our biologic prophylaxis or other forms of pharmacologic prophylaxis, and then continuing to monitor their disease activity over time and adjusting our therapy accordingly based on what we see. That brings us to our next dilemma. How do we actually monitor, grade, assess, and react to disease activity in this setting? I want to spend a couple of minutes here just talking about history. And what I'm going to be talking about is a study from 1990 published by Paul Ruckerts and colleagues, a group from Belgium, who've really been seminal in establishing the natural history of Crohn's disease and still publish very widely to this day on postoperative Crohn's disease. This study was, like I said, published in 1990, and it is still the gold standard for disease activity assessment in the postoperative setting. This is an endoscopic disease activity index. It looks at the final 10 centimeters of the small bowel right before it comes to that reconnection site to the colon, and it grades the degree of inflammation based on the presence and number of inflammation findings. So you can see in the top, there's a score that goes I0 all the way to I4. I stands for ileum, and it's basically a score of 0 to 4. 0 is completely normal. I means a couple of little pin dot ulcers in the small bowel. 2 means more numerous ulcers that are spread apart, or areas of larger, more significant degree of inflammation, or lesions that are confined to the anastomosis. And 3 and 4, as not surprisingly, are more significant, severe endoscopic disease activity. And that Kaplan-Meier curve in the top right there, published in 1990, showed us that individuals who have either I0 or I1 disease activity, so normal or barely abnormal, are very low risk for progressing to clinical or surgical recurrence, whereas the other scores, I2, I3, I4, in a progressive stepwise manner, essentially are at highest risk for disease progression. So what this means is that from a terminology standpoint, we really describe scores of 0 or 1 as endoscopic remission, and we describe scores of 2 through 4 as endoscopic recurrence. But I want to point out a source of ambiguity for many years in the postoperative world. If you look closely at this score of I2, there's a variety of different inflammation descriptions. There's also 2 distinct anatomic locations that are included in this scoring category. So this can include inflammation in the neoterminal ileum or inflammation that is simply confined to the anastomosis. And so what was really a question in the management world of these patients is, what do we do with this information? Is this risk really the same, or is there a differential risk by anatomic involvement? So there was a proposed modification to the Recurrence score, which separated these anatomic areas. And the I2 category was subcategorized into either I2A or I2B. I like monikers, so the way I remember this is the A in I2A stands for anastomosis. The B is for before the anastomosis or inflammation involving the small bowel. We can see in the top right photo there, the I2A is inflammation at the anastomosis. And you can see in the picture there, this is a reconnection site. It's kind of that ring-like appearance. If you have any trouble, you can always look for surgical staples. The surgeons like to leave their mark where they are, so you can identify staples and know you're at the anastomosis. And what we're seeing are ulcers in a circumferential manner around that anastomosis, but not extending into the small bowel. Whereas with I2B, we see inflammation that is extending into the neoterminal ileum there in the bottom right. So the question became, does this matter, or are we just kind of separating and creating points for ourselves to write new papers and publish? We looked at this, and this work was led by Dr. Salam Bashor, who's now a GI fellow at Mount Sinai when we were working together in Cleveland. And he clearly showed in a very large patient population from a multi-center effort that it's really the ileal inflammation that drives subsequent disease progression and recurrence. So we separated out by these different Recurrence scores, and we found that I2B, that small bowel inflammation, was at significantly higher risk compared to inflammation that was just described at the anastomosis. And this bore out in multivariable modeling, controlling for other risk factors for recurrence, over a 2.5-fold increased risk of disease progression if that small bowel was involved as compared to just the anastomosis. And I want to point out a separate learning point in this model, in this study, is that if a biologic therapy was started as a result of those endoscopic findings, we saw nearly a 50% reduction in subsequent disease progression once that biologic was started. So if we monitor, if we watch these patients and we react accordingly, we can perhaps alter that natural history paradigm and progression that I showed you early on. Well, most patients don't want to undergo colonoscopies every 6 months or every so often. It's an invasive procedure. It's got risks. It's costly. We utilize a variety of non-invasive measures to also look at disease activity in Crohn's disease. So it begged the question of, can these modalities also identify and detect disease recurrence? This was data from a European group that looked at MR interrographies to detect endoscopic recurrence of Crohn's disease. Long story short, yes, it can. This is a scoring system called the Monitor score, which can be used with fairly decent accuracy to identify patients who have a degree of inflammation that would meet our standards for describing as recurrence. Our group was looking at MRIs at the same time, and what we were doing is a little bit of a different spin. We were looking at patients who had concomitant cross-sectional imaging and colonoscopy within 90 days of each other, and then categorizing them based on the presence or absence of inflammation. And these were all reread images, reread endoscopies by IBD experts and categorized accordingly. And I want to draw your attention to a really interesting subpopulation in this study. These were patients, again, who had concurrent endoscopy and radiography. And this patient population was found to have radiographic disease activity. So on MRI, the radiologist or the expert radiologist said, there's active Crohn's disease here, there's recurrence. But when we performed the colonoscopy, it was almost completely normal or normal. And so the question then became, well, what do we do with this information? Is this Crohn's disease recurrent? Should we be acting on this subpopulation? And what we found is that if you look at these individuals who have radiographic disease activity in the absence of our gold standard endoscopic disease activity, they're at higher risk for progression. So this really begs the question of what is happening in these individuals that's different than that natural history of mucosal inflammation driving disease progression. We talk about Crohn's disease as a transmural inflammation process. So are these people actually starting from the outside and working their way into the mucosa? We don't really know, but it's an interesting phenomenon. Clinically, we also beg the question of, if we act on this finding, does it change outcomes? And there was a subgroup of these patients who were actually started on a biologic as a reaction to their radiographic disease activity. And we saw over a 50% reduction in the likelihood of subsequent disease progression. So clearly, again, if we monitor our disease activity, not necessarily only with colonoscopy, but with other modalities as well, we can perhaps intervene and intercept this natural history and disease progression. Biomarkers are big in Crohn's disease. One of the most commonly used one is a fecal calprotectin. It's released by neutrophils within the gastrointestinal tract when they're activated through inflammatory processes. That calprotectin is then measured in the stool with very high accuracy, and it correlates very nicely with Crohn's disease endoscopic disease activity. This data that I'm presenting in this slide came from another clinical trial in postoperative Crohn's called the POKER trial. And what this study was looking at is various time points postoperatively, when to scope and what to do with those findings. But what I'm going to be focusing on is they actually collected stool data as part of this trial. What they found is that calprotectin elevation at the time of a colonoscopy could very accurately identify individuals who had concurrent endoscopic recurrence. So a very nice tool at the point in time. But what they also showed is that if you measure the calprotectin, say at 6 months postoperatively, and the fecal calprotectin is elevated in this study above 100 micrograms per milliliter, you could actually predict who was going to develop endoscopic recurrence at 18 months. So a year lead time when those people did not have endoscopic recurrence at that 6-month time point. And the area under the curve for that prediction is 0.89, which if you do any clinical outcomes research is a pretty decent area under the curve. So really implementing calprotectin not only as a point in time measurement for what's happening, but also as a predictive tool when used and measured serially and longitudinally can be a very valid approach. And really what's been transformed in the more recent history is that the AGA took this biomarker data, and they put together a new guideline for how to implement and utilize fecal calprotectin in the postoperative setting. What they actually recommended, interestingly, is if this calprotectin measurement is so good and so accurate, can it actually obviate or supplant the need for endoscopic monitoring? And so what they recommended based on their technical review of the data and how they broke it down is that individuals who are at low risk for recurrence, and again, I put up those illustrative risk groups again. So older people, shorter disease, first surgery, whether or not they're on a sort of prophylactic medication, can undergo fecal calprotectin monitoring within the first year post-op. And if that's normal, that can supplant the need for a colonoscopy. However, if that's elevated, then a confirmatory colonoscopy is indicated. And in fact, they went further and said, if they're high-risk individuals, yet they're receiving a biologic prophylaxis because of that significant risk reduction when you use medical prophylaxis, you can do the same thing. But individuals who are high-risk, who aren't on medicine, that 80% likelihood that disease is coming back, it's just a matter of time, those people need colonoscopies. So we're starting to see a transition away from our gold standard endoscopic evaluation towards more biomarker, more non-invasive monitoring for this high-risk patient population. Admittedly, I'm not a translational scientist in addition to not being a microbiologist, but there are a lot of groups who are looking at omics as it relates to postoperative recurrence, and can we use certain signatures to identify disease recurrence. People have described tissue transcriptomics, urinary metabolomics, and proteomics, all being able to accurately identify individuals who are experiencing disease recurrence. So similar to that incorporation of a variety of different domains and dimensions for risk prediction, perhaps this will be coming to a clinic near us in the future, but more data and confirmation is needed before that rollout and that transition. I think the important point here is the 20,000-foot view, that no matter what we're doing, whether it's the prophylaxis, whether it's the looking, watching, reacting, calprotectins, interrographies, we're doing better. So this is data from Europe population-based cohort that looked at the risk of surgical recurrence. So these people have undergone surgery for Crohn's disease and looking at whether or not they need a repeat surgery for disease recurrence. And what we're seeing is that when you break it up into temporal cohorts, the most modern cohort encompassing 2012 to 2020 is seeing a significant reduction in requiring repeat surgery for management of Crohn's disease. And when they teased apart factors that were associated with this risk reduction, the only thing that bore out in their multivariable model was the fact that if you performed an ileocolonoscopy within 1 year of surgery and presumably reacted to those findings, that was an independent reduced risk of going on to develop or require repeat surgery. So we're doing better. Our modalities, our paradigms seem to be working. But the cold shower that we all have to take with Crohn's disease is that we're never out of the woods. Crohn's disease is a lifelong illness. We do not have a cure for it. There are genetic changes, immune system changes that happen in people who develop Crohn's disease. And this data is really a sober awakening to us, showing that even if we achieve our short-term outcomes, if we do surgery, we scope people and the scope is completely normal, there's nearly a 50% risk that those individuals will subsequently later go on to develop disease recurrence. So we're not out of the woods with Crohn's disease. And this begs the question of how the heck do we identify these patients? How do we predict this late recurrence and what do we do about it? Hot off the press, just published last month, our group looked at this patient population, these people who had completely normal colonoscopies, so no ulcers, no inflammation, even to a small degree, and people who were biopsied. And if we see evidence of histologic disease activity on those biopsies, that can identify an at-risk population over a twofold increased likelihood that those are the people who go on to develop late postoperative recurrence. All the other risk factors, aside from people who continue to smoke, didn't bear out as risk factors for predicting this late complication. So we still have a lot of work to be done, but it seems like histology is almost going back to that natural history slide that I showed you, that this natural history can present and evolve at any point in the postoperative course, despite our early successes. So again, a cold shower, a sober awakening for this high-risk patient population. So where do I think we're heading in postoperative Crohn's disease management and evaluation? I like to think that we're getting away from simple clinical parameters as our risk prediction tools and starting to incorporate some of this multidimensional evaluation and triaging, including things like microbiome signatures, tissue histology obtained at the time of surgery, tissue omics or other omics as the data guides us, and then this post-operative setting with intra-abdominal complications, taking that all together and perhaps translating it into more individualized risk scores. This is data that we're currently working on, and it seems to be promising that the more risk factors an individual has, the higher the likelihood of recurrence, and those are the highest risk patients that probably need a multi-dimensional or multimodal approach to postoperative Crohn's disease management, what I call postoperative combination therapy. So getting away from just using infliximab, vedolizumab, or whatever mAb you want to talk about, and really incorporating things like selective antimicrobial altering strategies, dietary strategies to shift and diversify that microbiome. And then in terms of monitoring and reacting to that, really transitioning towards non-invasive monitoring with confirmatory endoscopy. So in conclusion, for postoperative Crohn's disease, hopefully I've shown you that the natural history can be grim, that it happens in the majority of individuals. It's often clinically silent and influenced by risk factors that I've put up here, and that includes a variety of different domains. But early postoperative prophylaxis with anti-TNFs, vedolizumab for sure, and likely other mechanisms and other biologics can reduce endoscopic recurrence and hopefully start to alter or at least delay this natural history of disease progression. We still rely on endoscopic monitoring as our gold standard to guide postoperative management, but we're starting to see this transition towards non-invasive monitoring, including things like fecal calprotectin, MRIs, likely intestinal ultrasound. I didn't show that data, but it seems to be pretty promising. And really importantly, this is a collaborative disease state. We need medical, surgical, we need histology and pathology, we need radiology to help guide us in terms of triaging and monitoring these people. We have a lot of lessons to be learned, so I'm always looking for collaborators across institutions and disease states that we're always looking to learn and do better, because this is a high-risk patient population that deserves our best efforts. So to go back and to conclude the case, and again for a summary in the top right there, 32-year-old female, stricturing ileal Crohn's disease, actively smoking at surgery. She undergoes surgery and the pathology has that margin positivity with myenteric plexitis. We deemed her to be high risk for disease recurrence based on those factors: younger age at diagnosis, smoking, margin positivity. And so we resumed her adalimumab in the immediate postoperative period, actually about a week after surgery. And we were fortunate in that she was willing to stop smoking. We provided nicotine replacement and got her plugged in with our GI psychologist, and she successfully stopped smoking. Her fecal calprotectin measured 6 months after surgery was normal. Again, normal is less than 50 here. She went on to have a colonoscopy as well as an MR interrography, both of which demonstrated endoscopic remission and radiographic remission, just a single small ulcer in the ileum. I just saw her 2 weeks ago and she continues to do well from all parameters. I want to acknowledge my research collaborators across a variety of different institutions. A lot of the data I presented today comes from working with them. So I thank you all for your participation in this collaborative arrangement across centers. And I really want to thank you all for your attention, either attending virtually or in person. And I'm happy to take any questions. Yes, I am active on the X, so you can friend me or chat me there as well as email. Thank you again. Welcome any questions.
Dr. Click, thank you. What a great summary of the work you've done and really the complexity of care. I'm sure we have some questions, but I'll start us off. Post-op recurrence looks to be an incredibly complex decision point. And has there been outcome data looking at specialized IBD centers like ours compared to usual care in community GI clinics in terms of recurrence, surgical interventions, other health outcomes?
Yeah, that's a great question. It's a little bit of a surrogate denotation of whether it's an IBD expert center of care versus community care. There have been studies looking at the timing of surgery as kind of a reflection of IBD care leading up to that point. So there was a study out of UNC which looked at patients who underwent either emergent or urgent surgery as opposed to elective surgery for this type of scenario. So these are patients who had some sort of perforation or abscess that couldn't be managed non-operatively. And that basically showed that those people were more likely to receive kind of substandard post-operative care as well. So less biologic utilization, less post-operative colonoscopy monitoring. So it's kind of a surrogate way of looking at that. I don't think that question has been looked at with the exact categorization that you mentioned, but there's also recent evolving data, and we're hoping to explore this within our data set as well about disparities in care. So, measures of healthcare access, SVI, as it relates to healthcare outcomes. And there's some prelim evidence that there may be some suggestion that the farther you have to drive, the less wealthy your householders, if it is that they drive health outcomes like many disease states.
Thank you, Ben. That was great. I was, hearing when you were talking about early post-operative prophylaxis, and was wondering, I know there would maybe have to be a break, but have people looked at pre-operative, sort of preparing the tissue for then, and probably take a break at surgery and then restart it early, but kind of getting at this earlier to see if that could decrease the recurrence?
Yeah, what's really interesting is there's some conflicting data there, and we're still trying to tease this apart. We're actually trying to validate this in our data set. So two groups now have suggested that actually pre-operative anti-TNF exposure increases the risk for recurrence. And this is actually seen in several different situations within IBD. So patients undergoing colectomy and J pouch creation, for example, pre-operative and especially more numerous exposures to different mechanisms may tend to poor pouch outcomes. There's some data showing that anti-TNFs can alter the microbiome, so reducing that diversity going into surgery. This is all hypothesis generating, needs validation. So we don't really know, but it's almost a converse of that question, that we may actually be doing harm rather than just cutting everything out, starting de novo from kind of microscopically, macroscopically scratch and really intervening post-operatively. But the good news is, even if people are on pre-operative medications, the utilization of post-operative medication still seems to be effective. Blair.
Phenomenal as always. Thank you so much. I have two questions that are interrelated, and it's kind of towards the end of your talk, talking about this kind of sobering reality that even when we do a good job up front, we're still not out of the woods. We have a lot of data on what to do in the immediate post-op period, but how should we be following these patients over time to make sure we're not missing opportunity? That's the first question. The second interrelated question is, I thought I saw some data about taking biopsies early and seeing histologic recurrence, and maybe that's predicting late recurrence. there's this idea that maybe if it's the mucosa is not broken, we don't want to break it and introduce a bacterial insult. How do you, deal with that conundrum?
Ooh, that second one's hard. I'll take the first question first. So how do we monitor these patients in the long term? I think it starts even before surgery. So the challenge here is a lot of these patients have felt pretty poorly for some time. Then they go in and get surgery. And as you well know, they feel tremendous after surgery commonly. And they actually may walk away from us and go back home and never follow up or have a really delayed follow-up. So it's really important that we talk to them about this natural history, about this risk. And even when we achieve early success, you're not out of the woods. And this is a long-term monitoring paradigm that we need to implement. So it starts there. And I think even if we achieve that early success, talking about continued biochemical monitoring, continued non-invasive and invasive monitoring with gold standard ileocolonoscopy. But likely we see data from other studies as well as that group I showed you, mostly 50%, but there's still 50% who stay in deep remission postoperatively. So trying to tease that apart remains a challenge for us. But really kind of that longitudinal serial multimodal monitoring and having them buy into it. Do I know the exact time points and modalities that we need at XYZ time based on the risk factors? No, not yet. But it's really kind of that collaborative patient-provider relationship that's important. Yes, Dr. Christie.
Great talk. So for some of or many of our colleagues in the room who may be sort of the front lines of primary care docs in the room, what's a scenario in which maybe they don't come back to us after surgery and GI, but they're seeing their primary care doc and they're kind of doing okay, not really sure. At what point should the primary care doc say, hey, let's get a fecal calprotectin, or let me send you back for a colonoscopy? What are some of the things that we should be looking for in the room?
Yeah, well, that's a great question, Dr. Christie. I think high level wise, all of these people should be continued to be followed by gastroenterology and really recognizing that even if you're sending your patient for surgically induced remission, they still have to come back and see you. Ideally, you have a plan going into surgery as a gastroenterologist about this is what I'm going to do post-op and telling the patient that plan. Say, I know you're going to feel good. Come back and see me. We're going to do a fecal calprotectin at 3 months, at 6 months. We're going to scope you, scan you, all these sorts of things. And you're going to say, why do I have to do all this? Because I feel so good, but this is the natural history, similar to the question from Blair. So really, hopefully not losing that relationship as part of it is the first line response to that. As a primary care provider or internist or other specialists is seeing and interacting with these patients, hopefully checking in and just seeing that they are continued to be established or remain in some way followed by the gastroenterology team is perhaps the most pivotal point that they can do. Checking a calprotectin, I'll take a calprotectin at any time. That's my mantra is I can always put it into context and navigate it. And certainly if it's normal, like I showed you, that's reassuring, but abnormal has to be followed up in that setting.
Yes. Do you know if there's any, I'm not sure how you get this, but is there any long-term mortality data?
Long-term mortality risk or data?
Yes.
Is that the question? Okay. Good news is that mortality overall in Crohn's disease seems to be very minimally impacted. So there is a slight mortality risk with Crohn's disease that's most commonly driven by individuals who undergo massive or repeat resections. The good news is we typically aren't seeing as many of those patients with such massive small bowel resections that they're in short gut syndrome territory and suffering from malnutrition. Our nutrition management has gotten a lot better. We actually have centers that do things like small bowel transplants now. So the good news is we're hopefully making strides with that, but it's a very small risk overall. And the hopeful silver lining here is that despite the morbidities, despite the natural history and grimness that I spoke of, it's overall a low, if any, mortality impact.
Great talk, Ben. A quick question about therapies that are available postoperatively. You had shown data that we now have 2 classes that have had placebo-controlled trials that show that there's benefit in the post-op setting in the anti-TNFs and vedolizumab. And then commented that the placebo-controlled trial remains the gold standard for identifying other mechanisms of action that might be useful. Do you think with 5 classes of advanced therapies that currently exist for Crohn's and UC that there's still like clinical research equipoise for us to be conducting placebo-controlled trials in these high-risk individuals?
I think that's an even bigger, not even just limited to the postoperative setting, but IBD overall, that we need change, and this change has to be driven by the regulatory people involved, so namely the FDA and the European societies that regulate this, wherein they still mandate placebo-controlled trials in IBD to get regulatory approval for that disease state. And in postoperative recurrence, they actually, with the PREVENT trial, they mandated a primary outcome of clinical recurrence. So I showed you the endoscopic data. That was actually a secondary endpoint, but the primary endpoint was FDA mandated. And we know clinical recurrence is delayed. You can't do a 1-year trial and expect to see clinical recurrence differences. Even in the Reprevio trial, which had clinical recurrence data, it was exactly equal between placebo and vedolizumab. So we need buy-in from regulatory agencies to make that transition. Do I think we have equipoise? Yes, I think everything should be measured against anti-TNF as a baseline. And then you can find other niche studies comparing different mechanisms of action. But hopefully, I don't know what it's going to take. It's probably going to be some regulatory change and adjustment, some lobbying from us as the medical providers in this regard, but we've got to see a change from them before industry will respond to that.
Ben, thank you so much for a great grand rounds.
Thank you.